So, welcome everyone, and thank you so much for joining us today. My name is Paula-Riitta Huttunen, and I serve on the board of TTEC. I'm also the chair of the Events and Webinars Subcommittee, which is part of TTEC's Global Research Committee. I'm very happy to be hosting today's session. Today's webinar, Cannabis in Tourette Syndrome, the Evidence, the Promise, and the Perils, is the first in a two-part series focused on cannabis and Tourette Syndrome. We are very pleased to welcome Dr. Elia Abi-Jaoude, Medical Director of the Ambulatory Psychiatry Program at the Hospital for Sick Children in Toronto, and a leading expert in developmental neuropsychiatry. Dr. Abi-Jaoude will guide us through the current scientific evidence regarding the use of cannabis in treating tics, as well as the potential benefits, risks, and challenges of cannabis-based interventions for Tourette syndrome. Before we begin, just a few housekeeping notes. Please keep your microphone and camera off throughout the presentation. If you have any questions for our speaker, feel free to post them in the chat at any point during this talk. I'll be collecting your questions, and we'll have about 50 minutes at the end of the session dedicated to this question and answer session. I'd also like to take a moment to invite you all to our second event in this series titled The Highs and Lows of Cannabis in Tourette Syndrome. It will take place in a couple of weeks, Friday 25th of April, and will feature lived experiences and a broader discussion of the role of cannabis in Tourette care. You can find more information and register via our website, ticsandtourette.org. I can post a link to chat. And once again, thank you for being here with us today. And now let's warmly welcome Dr. Elia Abi-Jaoude.
All right. Thank you very much, Paula-Riitta, for the introduction and for all the work in organizing this. And thank you to all the rest of the TTAG team for this. And especially thank you all who are attending today, different time zones from around the world. I appreciate people being here to listen to this presentation about this topic. It's a topic that's been of great interest of mine, and it's an area that I've been involved. Our group has been involved in, and I've personally been involved in for over 15 years now. And this we came about this topic really from patients, basically patients inquiring about this, talking about their experiences, which is what got us interested in this. And then it's been a very interesting journey all along the way. There's been dramatic shifts also in terms of the landscape, people's attitudes and culture towards cannabis. It's been fascinating. I'm happy to say that we've been involved with this way before all the hype. And I use the term hype deliberately because I think it's gone to a bit of an extreme more recently in terms of people seeing cannabis as often a panacea for everything. So I think again this is an important and very worthwhile topic. Cannabis, I do think, is a promising agent. We just have to be thoughtful about how we approach this topic and use it. And this is going to basically the overall general preamble of my talk. I'm going to try to go quick because I have a lot that I want to cover, and I want to make sure that we have adequate time for questions and answers at the end. All right. So I want to make sure. Okay, there we go. So I have no financial conflicts of interest to declare myself, but I do want to say that there has been a lot of money in this area as well. And so there are companies that have been very active in promoting these things. So that's something we need to be keep in mind. Okay, so learning objectives. So my hope is by the end of today, you'll be able to describe the current evidence for cannabinoids in the management of tics. And I'll go over this a fair bit. I'll try not to overwhelm you, but I will pretty much cover all the evidence there is. And there are different types of evidence, which I will emphasize. I will talk about when to consider cannabinoids in the management of tics for adults with Tourette syndrome. we can talk about it, and we will actually talk about what about the case of adolescents. We will that by the end also you will be able to describe the benefits and harms of cannabinoids, and then you will be able to consider practicalities around administration of cannabis. And I just want to say I'm hoping we have a good discussion Q&A at the end, but we have a whole session dedicated next week on Friday that's going to be much more interactive in terms of, and there's going to be much more discussion for a lot of things as well. Okay, so as a quick overview slide, and I imagine most people know these things, but I want to make sure everyone's on the same page. I want to set the stage for where cannabis comes in. But we need to start with the basics. So first of all, even starting with what Tourette syndrome is. So Tourette syndrome is a condition defined by the presence of motor and phonic tics. Tics have a typical course where they begin in early childhood, usually around ages 5 or 6, and then even as they fluctuate, they tend to peak in severity around age 10 to 12, so early puberty. And then after, for most, there's a gradual decrease in tics. Okay, so and this is an important message to know when we're working with young people, that about 80% will have minimal to no tics by the time they're young adults. But not everyone. Notice I said about 80%, even 75%, some people say, but so a good fifth to a quarter of patients will not outgrow their tics and will continue to have significant tics as adults and throughout their lives. How do we manage tics? So most tics, or a lot of the time, the tics are mild to moderate. And really, the main issue, the challenge is not the tics from themselves directly, but more the environmental reactions to the tics and the challenges that brings both at home and outside of the home, whether it's a school or the workplace. So education and reassurance is a big part of our message, a big part of our management. And often for those with mild to moderate tics, often that's all that we do. That's nothing else more needed. But for people with more significant tics that are more problematic, and tics can certainly be quite problematic for various reasons, could be physically problematic, or interfere with function. Socially they can be very much a problem and such. So when we need to target tics, the first line targeted treatment for tics is behavioral therapy based on habit reversal training primarily, but also there's a similar approach called ERP, exposure and response prevention. That is also a behavioral therapy option for tics. And it's the first line targeted treatment by all clinical practice guidelines. Okay, there are multiple clinical practice guidelines for Tourette syndrome, and there's some variations across them, but one thing they all agree is that behavioral therapy is the first line targeted treatment. When medication is needed, we have several options, but the two mainstay medication classes are either the alpha-2 agonists or the antipsychotics. So that's when medication is needed for tics. And then last but not least, I want to emphasize that Tourette, in the majority of the time, Tourette syndrome is not just tics. So 90% of the time, there's at least one comorbid condition, in particular OCD and or ADHD, but rage outbursts and a whole long list of others can be included. And often these need to be part of the targeted management as well. Sometimes these are even more bothersome than the tics themselves. So that's something that is part of what we work with Tourette syndrome. Okay, so now that we are all kind of hopefully on the same page around this, let's go into the medications for tics. Okay, because we're talking about cannabis today, and I consider that a medication for tics. So let's look in a little bit more detail here. So I'm showing you here the recommendations from the clinical practice guidelines from the American Academy of Neurology. They were led by Dr. Tamara Pringsheim, who's a neurologist in Calgary and in Canada. And these are guidelines I think are particularly good, which is the reason I've chosen to highlight them. And what they have there is the alpha-2 agonists, so clonidine, guanfacine, if people have heard of these medications, are given level B evidence, meaning that they tell clinicians that they should recommend them as an option, or should discuss them as an option for patients with tics. But the level of confidence in the evidence is not great. The quality of the evidence is low to moderate, how it was classified. Okay. The other medications are antipsychotics. There's more confidence in the evidence for antipsychotics, moderate confidence. However, they received a level C recommendation, meaning that you may talk about them with the patient as opposed to you should. And the reason, even though the evidence is better than the alpha 2 agonists, but they still got a a weaker recommendation compared to alpha 2 agonists, is because of the adverse effects. Okay, so the harms from these drugs are they can be quite concerning. So that's why they're not given as high a recommendation. I mean, the alpha 2 agonists have their own adverse effects as well, but the ones from the antipsychotics would be more concerning, particularly when we're talking about children. Uh, Anything related to adverse effects was the only thing in all, and I'm not going through all the different medications and the classes they covered, because it's a long list and beyond our scope for today. But I am covering these two are the main ones, but nothing received level A recommendation with regards to pursuing these as treatment for tics. The only thing that received level A recommendations was anything related to adverse effects. Okay, talking about adverse effects with patients, monitoring for them, etc. But there is a whole class of other medications, as I mentioned, that we talked about, and one of them is THC. Okay, so 9-delta tetrahydrocannabinol, which is the main active ingredient, one of the main active ingredients in cannabis. And what they say is they give a level C recommendation, meaning you may discuss it with adults. They specify adults. They in their evaluation of the evidence was low confidence of the evidence, though mind you, I will point out these guidelines were published in 2019. So the most of the evidence I will cover today has been published since then. But nevertheless, at that point, low confidence, and level C, meaning you may recommend it with in places where it's legal. Okay, because medical cannabis is not legal. All right. So how did I get into this? As I mentioned, this was very much driven by patients. I had just finished my clinical training back in 2009, and one of the the early patients, one of the first patients I met was a young patient, a young adult patient, basically, had just become an adult, and was there specifically not to for like that patient had known Tourette syndrome lifelong, had been followed by a psychiatrist. So the only thing that patient was asking was cannabis for tics specifically. And that patient, the reason for this was the patient had been at a party. There was a cannabis joint being passed around. She smokes a little bit. And then when she went home, her family noticed, hey, where are your tics? You don't have any tics. And so put two and two together, and then she was using cannabis for her tics, but she did not want to use it illegally. She wanted legal medical cannabis. And I was hesitant. I had never used medical cannabis. I didn't know the process or anything like that. And I was concerned. I knew the evidence was limited, especially at that time. And I knew about the potential harms. So I was telling her about these, and then she interrupted me and she said, I've gained 50 pounds on risperidone. I've slept through high school on clonidine. This is working for me. Like, don't tell me this is, worse than the medication you prescribe. And she had a point. So we figured out the process together at the time, and that's how I started pursuing cannabis. But we kept hearing, not just myself, my colleagues at the clinic, similar stories over and over to patients. So over time, we started even actively using it, and even when patients did not bring it up, that we would consider it as an intervention when they had failed multiple treatments, and oftentimes we were quite struck with the positive results. So, and I have to say, this was all in adults. Okay, so we'll talk about the case for children or adolescents towards the end. So we've been studying this, but I think it's a story in progress. It's a fascinating story. And let's talk about the legal aspects, though, because what we have done over the years has been very much influenced by what we could do, okay, legally an issue. And I'm going to give a very brief kind of history and very brief timeline of the legal history of cannabis in Canada. And I'm talking about Canada because that's what I know well, and I know people who are attending this come from all over the world, so it's going to be very different from one place to another. But there are a couple of points that are going to be relevant regardless, that I want to make general points. But to start with, that cannabis was criminalized in Canada in 1923. Okay, it's just over 100 years ago, about a century ago, and that's been the case for most of the past century. And it was only in 2001, just over 20 years ago, that medical cannabis was legalized. Okay, so this was specifically not just for any use, specifically for medical use. And it was when some patients for different conditions who found it helpful, and they said it was, they sued the government that they could not access it legally for their medical conditions, and then eventually it was legalized. But it was specific. It was only dried herb, so the dried marijuana herb, and only THC. Okay, so it was THC-based product. And this was the case for most of the fall, like for over a decade. And then things changed in 2013. So previously, you could only obtain this through the Health Canada, basically, our drug regulator in Canada. But in 2013, Health Canada wanted to get out of this. And then it started giving licenses to producers to produce medical cannabis. And so in a very short period of time, there were dozens of licensed producers. And as a result, there were hundreds of different products. Went suddenly from having only one single product to hundreds of products. Now we were talking about no longer just THC and CBD. So hundreds of products with all sorts of combinations of THC and CBD. But it was still dried herb we're talking about. Okay, so that's all we could do. Patients I had who did not want to inhale, they wanted to take it orally. There was no legal option to do that. They cooked it at home into cookies, but then that was their own thing that they were doing. And then in 2015, it was not until 2015 that two other additional forms were legalized. Again, we're talking medical cannabis, and was cannabis oil. So now you could take it orally, and fresh buds, not just the dried flower. And then something very big happened in 2018 in Canada, is that recreational cannabis was legalized. So at this point, they didn't need any doctors or medical reason to use cannabis. It was just like using alcohol. Recreational cannabis was legalized and people could use it, and there were been all sorts of forms of it. And then a year later, cannabis edibles and drinks and topicals were legalized. So I have to say there's a variation across provinces in Canada. Okay, but at the federal level, this has been legalized. So my couple of points, the reason I go through this is that it's changed over time, but most of it's much more recent that cannabis and marijuana has been available legally as a medical agent. It's shifted over time. There's complexity with it. And now even recreational cannabis is legal in many places, such as Canada, where physicians are not even needed, right? Patients can try and experiment themselves. It's their role for the physicians or the medical establishment to be involved in this. All right, so this is the case in Canada. As I said, there's a lot of variability around the world. But the pendulum has swung dramatically from people being very wary to now there's across where I live in the city of Toronto, there's many stores selling cannabis and clinics advertising their services for medical cannabis. And it's really gone to an extreme where it's been kind of touted like as a panacea for so many things. And this is just a list here. I have here in big this is from a flyer I received advertising from a clinic, these private clinics advertising their medical cannabis. And look at that, the commonly treated conditions: anxiety, PTSD, ADHD, depression, insomnia, stress, panic disorder, bipolar disorder, type 2, borderline personality. So, I mean, really? It is really, and when you have something that is used for, that is supposedly treats everything, we have to be highly suspicious here and careful. Okay, this is goes back to like the snake oil salesman, where it's something is good for everything. So we have to be careful. And indeed, Ruth Ross, who was the chair of our pharmacology department here in Toronto, wrote a strongly worded opinion piece why we need to press pause on any kind of cannabis promotion. Many companies are selling marijuana as if the drug is totally harmless. It's not. Okay. So we need to keep that in mind, even as we pursue this in our field of Tourette syndrome. So I've been talking about cannabis generally, and I mentioned briefly THC and CBD. I just want to say a little bit more about them so people are aware of what we're talking about in terms of the agents. So the two main agents that we talk about are THC, 9-delta tetrahydrocannabinol, and CBD, cannabidiol. Okay, what do they do in the brain? Okay, so THC is a partial agonist of two receptors in the brain that we've called CB1 receptor and CB2 receptor. So partial agonist means it stimulates these receptors. Okay, partial means it doesn't stimulate them to the full extent in which they can be stimulated, but it does stimulate them. And these receptors, by the reason we have them in the brain is we have neurochemicals in the brain that we refer to as endocannabinoids. So they're endo, that means they're in our brain, and they stimulate these receptors. So THC acts on the system. Okay, it's a partial agonist to these receptors. CBD, that is, and this is a mouthful, so forgive me, but I'll explain it. Negative allosteric modulator, meaning it changes, it's an allosteric modulator. It changes the shape of these receptors such that you don't have as much of an effect of an agonist. Okay, so that's where the negative comes in. So whether it's agonist effects of THC or agonist effects of the endogenous cannabinoids, so it decreases effect on these two receptors. So to make it more simple, it has a bit of the opposite effect, or decreases the effect of the agonist. So that's THC and CBD, and that's what we typically measure. That's what we talk about. And when you get a cannabis product, often you'll have the percentage of THC, percentage of CBD. However, there are hundreds of other compounds in cannabis that we don't measure and about which we know very little. Okay, so that's something to keep in mind. And also to be aware then when we're using a cannabis herb, it's going to be very different than if we're using purified THC. Okay. The other thing are the terpenes. Terpenes is what gives the smell, the flavor of cannabis. And they may not be entirely neutral. Okay. So people talk about them having what we call an entourage effect, meaning they may impact the effect of THC, CBD, or other compounds by their presence. Okay. So that's so to tell you, this can be quite complex. And even though we have a very interesting evolving story, there's still a lot to learn. Excuse me. What about the products themselves? So you can have pharmaceutical grade cannabis. So it's like a pharmaceutical, like any. Cannabis can be inhaled or it can be consumed orally. Okay. Pharmaceutical cannabis, these are the agents as far as I'm aware. There may be some parts of the world where there are other options that I'm not aware. But nabilone is a synthetic form of THC. Dronabinol is basically THC. So these two are basically THC. And then at the very bottom, cannabidiol, that's CBD, so the pharmaceutical CBD. And then something called nabiximol, Sativex is the brand name in case you've heard of it. It's a spray of roughly equal measure of THC and CBD. Okay, and so these are options for pharmaceutical. When we talk about inhaled cannabis, it can be smoked, like rolled in a joint and smoked, or pre-rolled. It can be vaporized, so you put the herb and it's in a vaporizer, and the herb is heated up, and then that's what you inhale. Or it could be vaped. So vaping, which is common today, unfortunately, among many adolescents, vaping nicotine commonly, but it's a whole other subject. But basically, you get a cartridge, and the product is in some form of liquid, and which is heated up, and that's what you inhale. Okay. If you have to, our preference would be to take cannabis orally, but if you have to inhale, then the choice would be vaporizing to minimize negative impact on the lungs. Orally, Can be in oils, capsules, edibles, such as cookies, chocolates, and such. And there are other forms in drinks now, in topical creams and such. That's more recent and not as much known. All right. What about the effects? The known benefits for cannabis is they're anti-emetic, so they make decrease nausea, basically. So this patient, especially with patients getting chemotherapy for cancer, appetite stimulation, patients markedly decreased appetite. They can decrease pain. In multiple sclerosis, where you get significant spasms, you can have antispasm effect. And anti-seizure, this is specifically CBD, cannabidiol, in some rare forms of epilepsy, Dravet syndrome, Lennox-Gastaut syndrome. Cannabidiol can be life-changing. Okay, CBD. Um, what about the harms? Like pretty much everything, the list of harms is much bigger. And just to go over them quickly, dizziness is quite common, sedation, fatigue, psychomotor slowing, the feeling of high. And it's listed here as a harm because patients experience this negatively when they're trying to use it for their condition. They don't want to get high. It's not like using it at a party, right? They want to be able to function and such. Decreased motivation, depression, irritability, anxiety, derealization, depersonalization, altered perception, psychosis, dry mouth, and red eyes. Okay, these are common. Of course, the list is much longer, but I would say these are the common ones. It doesn't mean that people will experience these things, but these are common to experience. Okay, and they're pretty much all dose related. All right, what about the evidence? Okay, I'm going to cover the evidence, all of it, and that's not a ton of evidence, unlike other fields. So I will be covering all of it. But again, the point is not necessarily to get into all the weeds, but to understand the kind of general uh, patterns, and I will highlight some themes that I want to bring to your attention. So there are three types of evidence. So retrospective studies, meaning I have a bunch of patients who are taking cannabis already and so I'm gonna study them. Well, that's maybe not the most objective kind of evidence, right? Because it means these are the patients who have decided to stay on cannabis because they're benefiting from it and they're able to tolerate it fine. So, but nevertheless, they're useful. Okay, so I'll talk about that. There's open label studies, meaning these are studies where you said, okay, I'm gonna use cannabis in, let's say, my 10 patients, and I'm gonna study them going forward. Okay, so these are a little less biased because you're following patients prospectively. You're giving them the product, and you're following and seeing how they do, both positive and negative, and they might not continue using them. But they're also biased because they're open label. You know what you're getting. There could be placebo effects, and you might be biased and such. So the highest level of evidence is what we call the RCTs, randomized controlled trials, double blind. So the clinician doesn't know what the patient's getting, the patient doesn't know what they're getting, and they're randomly assigned to get either cannabis or a comparator. So I'll cover these as well. And you'll see that the results are different depending on the evidence that we're looking at. Okay, retrospective studies. Again, don't worry about it. The details here, I'm going to cover the main things here. The first study, the main study, I would say, everyone refers to, published by Kirsten Müller-Wahl, who's a neurologist in Germany, and back in 1998. So she's really been a pioneer in this field. And she interviewed several dozen patients, and 17 of whom had tried cannabis for their tics. And she found that of her 17, 14 reported that when they took cannabis for their tics, they had a decrease in tics and related symptoms. Okay, and so that was interesting, and she pursued other studies since, but there wasn't the interest in the rest of us, the rest of the world came around much sooner, okay? And a whole bunch of us have published retrospective studies as well, including our group. We published one. 17 out of 18 patients were rated as very much or much improved with cannabis. And this has been the theme with the other groups that have published retrospective studies. But what I want to highlight here is a couple of things of interest. Well, Well, the main one I want to highlight really is one thing here is what this is published in 2019, and this is also Milo 7 colleagues. This is also from Kirsten Muller-Wahl's group in Germany. They studied 98 patients who had tried different forms of cannabis, and they found that there was a preference for actual cannabis as opposed to the pharmaceutical cannabinoid, and then specifically for THC rich, that the effect was coming mainly from THC. We found the same as well, but this was not included in our published paper, but similarly, because we tended to start with pharmaceutical cannabinoids, and we found that most patients had more of an effect from the actual cannabis. At that point, I want to say is all of this is in adults. There were some isolated case reports, and in total, the pediatric age, there were only 7 cases. Okay, this has changed more recently, as you'll see. Okay, what about the open label studies? There are 2 open label studies, and already you see the effects are much lower. Okay, you still have positive effect, but here we're talking about 20% improvement in this study. Look, it's a small study, only 16 patients who received 12-week open label THC. And then this is an 18 patients also open label cannabis. And here 38% improvement. The YGTSS, in case people are not familiar, is the Yale Global Tics Severity Scale. It's considered the golden standard for evaluating tic severity. Okay, and this is the total tic score. So 20% improvement, 38% improvement. This is more significant, more substantial, I should say. What about the randomized control trials? So, okay, I'm going to go over them quickly. I'm aware of the time here. So, in this one, you'll see Kirsten Muller-Wahl again, and this was a randomized control trial of single dose of either oral THC or placebo, and using this symptom severity scale rating, the THC group went down by 14 points versus 5 points in the placebo. Okay, and this was statistically significant. So, but it was a single dose study, just after a single dose. She then had another study, 24 adults, and this was an RCT, and she found that the overall impact on this Tourette syndrome symptom list severity rating was overall significant, but there were inconsistencies. It wasn't throughout the study that there was a thing THC was superior to placebo. She did another study. Again, you see, she really has done a lot in this field. And this one I wasn't sure whether to include this one or not because it wasn't cannabis, but it's a product that influences our endogenous cannabinoid system. Okay, so basically, this product, monoacylglycerol lipase, MAG, lipase inhibitor, it influences the enzyme that breaks down our endocannabinoids, okay? And it inhibits it. And as a result, in theory, it should increase the availability of our endocannabinoids. This was 49 adults in a 12-week study. However, the drug failed quite miserably. In fact, it was statistically significant in favor of placebo. So the placebo group did better than this product group. But the reason I did include in the end is to point out is that there are ventures to go into these synthetically produced products, but we have to be careful. Not all of them are equal, and they have to be studied carefully. And there are 4 other RCTs, okay, including a very recent one. And I'm going to go over these in a little bit more detail because I think it's worthwhile, okay? First, one by, again, Kirsten Muller-Wahl, and this was published just 2 years ago. It was an RCT of the nabiximols, so the spray, if you remember, and which has about equal parts of THC and CBD. And each patient received either anywhere from 1 to 12 puffs a day. Okay, so things were titrated based on need to get a response, or based on and based on adverse effects. So the total dose, the maximum dose was basically 32 milligrams of THC equivalent, okay? And they were randomized in a 2-to-1 fashion, meaning that there were twice as many that were randomized to the nabiximols group as the placebo group. Things were titrated up over a 4-week period, and then they remained for 9 weeks on the stable dose, so that the total length of the study was 13 weeks. What did they find? So this is what you see. This is the decrease in the YGTSS TTS, the total tick score, and you see the nabiximols goes down, and then the placebo goes down. But the difference is not huge, okay? If you look at the actual points, the difference is not very big. And then it's not statistically significant. So this was basically a negative trial, and 95% of participants had at least one adverse effect, okay? So not a great result for the nabiximols. Here's a study that we did in Toronto. And the purpose of the study, because there's a lot of talk about CBD. In fact, we had submitted an application for cannabis, and it was not funded to study cannabis. It was not funded because we were told, oh, but what about, how do you know the impact of THC versus CBD, etc. So we studied that. So this was a single dose, double-blind study where each participant received a quarter of a gram of either THC or a combo of THC and CBD, or CBD or placebo. And what did we see? So this is a crowded slide, but because each line, so each patient was, we looked at the different time points that we measured their symptoms, and each line represents one of the different products. And this turquoise/teal color is the THC, and you see there's a signal there. This is a video tick rating scale, but it was not statistically significant. Okay, there wasn't enough difference there. But on other measures like the premonitory urge for tick scale, okay, it went down pretty significantly for the THC, but not for any of the others. Same for the subjective units of distress. Okay, so basically we ask the patients how things are going in terms of their symptoms and overall, and you see much improvement in the THC arm, but not in the others. What about if we correlate with blood levels? Again, sorry for the crowded slide, but I'll just walk you through this quickly. We measured blood levels at the different time points of THC, CBD, and also of their metabolites, so hydroxy THC, carboxy THC. And this is the main active metabolite of THC, hydroxy THC. And you can see there's very significant correlations and strong correlations between the higher the hydroxy THC you have, the better the score, the change in score on the video tick rating scale, on the premonitory urge for tick scale, and on the SUDS, okay? In contrast, if you look at the CBD, there was zero impact at all of any relationship between the CBD level and ticks. With regards to adverse events, though, effects, you'll see here that it was much higher in the THC. First of all, it was much higher with any cannabis product compared to placebo. And then among the three cannabis products we had, the THC was the one with the much higher adverse effect. Okay. And then I want to cover this RCT. This one is from a group in Australia. And this one is a crossover RCT, meaning that patients were received of comparing cannabis versus placebo. And so they got one product for 6 weeks, then was 4 weeks washout, then the other product for the other 6 weeks. It's 22 patients. And this was a cannabis oil, and the dose was they received doses of 5 milligrams, so equal parts THC CBD, and the dose varied anywhere from once a day to 4 times a day. What did they find? They found actually pretty significant effect, and it's a very nice figure, but because of time, I'm not going to cover the whole thing, but I'm going to cover the main. At the very top panel here, you see the Yale Global Tick Severity Total Tick Score, okay? The green is the cannabis product. The yellowish is the placebo. And you see at start, this is the individual participants. This is the range, and the average is the dashed line. And this is it's called rain cloud plot, I think. But anyhow, you see there's pretty much full overlap in the beginning. But as the study goes on, you see more and more separation, so that you have a clear separation, significant decrease in symptoms with the THCs, the CBD combo, the cannabis group versus placebo. okay? And this was the case with their other measures as well. The other thing that they found, similar to what we found, is that there was a significant relationship between the blood levels of here, they look at carboxy THC, okay, and symptom decrease in their different measures, okay? So the higher the higher the level of the blood levels of the carboxy THC, the bigger the symptom change. Okay, so you have a significant decrease here. But the other important thing also to be aware of is similar to us, they found no relationship basically between CBD blood levels and symptom change. Also, adverse effects. This was it was not insignificant. 40% of the cannabis group had cognitive difficulties, 35% fatigue, 35% increased appetite. It's not most of them, but it's a lot of them. Okay, so to be aware that we're talking about active agents that can be helpful, but can have negative effects. And then this is the last RCT I want to cover. So it's also from Australia. So remember, I covered the big symbols one in detail from Kirtan Murerval, the one we did in Toronto, and then two from Australia. So the first one I just finished from Australia, and now this one that was just published a few weeks ago. And so similar design to the other one from Australia. It's a different group. It's not the same group. But what's different here is that this is in adolescents. So this is a big deal, okay? It's a small, very small study, only 10 participants, and from the outset, they say, this is not a study to see the effects of benefits or anything like that. This is a feasibility, acceptability study to see if can we even study this in adolescents, okay? So it's kind of like it's a pilot study. And they used a combo of THC and CBD oil. So 10 milligrams of THC to 15 milligrams of CBD. The dosing, won't cover in detail, but basically was based on weight, whether you are aware. Well, I'll cover it. It is important for those of you who are familiar with the dosing. If you're less than 50 kilograms, you were started at 5 milligrams. The initial target, sorry, you weren't started 5. You were titrated up to 5 milligrams a day. And then if you did not respond, then it was increased to 10 milligrams a day. The initial titration was over 3 weeks, and then subsequently to 10 if you did not respond. And then, I have a typo here. If you're over 50 milligrams, sorry, 50 kilograms, then the initial target. Okay, I'm sorry. I just mixed up how I explained this. I'm going to repeat, so forgive me. The initial target was either 5 milligrams or 10 milligrams a day over a 3-week period, okay? So if you're less than 50 milligrams, 50 kilograms, the initial target was 5 milligrams a day. If you're over 50 kilograms, the initial target was 10 milligrams. If you did not respond, then it was later increased. If you're less than the 50 kilograms to 10 milligrams a day, if you're above to 20 milligrams a day. Okay, here's the typo. The default was once daily dosing, interestingly, and only in those that were having adverse effects, it was divided into twice daily dosing. And similar design, as I said, 10 weeks of one agent, either cannabis or placebo, 4-week washout, and then 10 weeks of the other agent. So what did they find? So again, their main concern was not the benefit. I'll mention quickly, but it's too small a study with questions around it to make much of the benefits. This is not the goal of the study. The goal was feasibility, acceptability. Out of the 10, 3 dropped out, so 30% dropout rate. Medication adherence was 64%. Parents overall, from responding to a series of questions, that them showed high acceptability rating. So most of them felt that the study procedures were acceptable. And in terms of adverse events, it was not insignificant. So 67% had dizziness, so quite significant. And the other, fatigue and mental disorder, they don't describe what they meant by this, but there's a whole list of others that were experienced less frequently. But I'm just pointing out the main ones here. And here's my main concern about the study, is there criteria for who was included, okay? So they included adolescents ages 12 to 18, needed to be have a diagnosis of Tourette syndrome, needed to have a total tic severity score of at least 20, okay? no change in interventions in the 4 weeks prior and during the study, and that they agreed not to drive. Those were their inclusion criteria. What is missing from there? What is missing from there is the requirement that they have tried or our main treatments. So the requirement that they've gone through behavioral therapy and failed, that they've tried our main medications and didn't work out either due to lack of benefit or adverse effects. So we're exposing these young kids, as young as 12, to daily cannabis who may not necessarily have tried our main treatments before. So I think this is something we need to be very careful as a field if we're going to be studying this, and we should, in adolescents, okay? All right. In practice, I'll cover this very quickly because we are at 1:45, and I want to make sure we have time for a Q&A. The points, what are the guidelines from the American Academy of Neurology around cannabis? They emphasize adults. Specifically, either they're treatment resistant, meaning you've tried the main treatments and they continue to have significant symptoms that have not responded to treatment, or they're already using it and it's working out. So then you should be involved as a medical professional. They recommend medical supervision, using the lowest possible dose, periodically reevaluate whether it's needed, and then giving guidance around driving and cannabis. Okay. The products I've already covered. So initially, these are the options. And as I said, now that we have oil, my preference is for the oils, oral. But often patients, they're positive, find it more positive to use the inhaled. You get more of an immediate effect. It's easier to titrate immediately, in which case then the recommendation would be vaporizing. Okay. We need to be cautious about the harms. This is not a benign agent. And then the functional impact, if it's having a lot of psychomotor adverse effects, how's the person able to function, and could be from other adverse effects as well. Psychosis and mania, I have seen that. Thankfully, I would not say it's a common reaction, but I have seen it. We have to be careful. These are serious reactions. For those of you who prescribe, to be mindful of interactions with other agents that influence this enzyme system. I would caution against smoking it, basically. You're inhaling all sorts of things into your lungs. So again, if you want to inhale, the recommendation would be preferable to vaporize. Cautions about driving, and then legal things, right? In particular, traveling, okay? Crossing borders. It could be legal, even like someone going to the US, which is right next door to us, and it's legal in many states in the US, but it's not legal at the federal level in the US. So you can't really cross the borders with it. So to be mindful of that. So in conclusion, it is very promising that THC is promising. It's very much the evidence is altogether showing that it can have a benefit for tics, but can also cause harms that we need to be aware of and monitor for. With regards to CBD, there's really no clear anti-tic effect, okay? And it gets a lot of hype, this one, but it can be very useful if you have these rare forms of epilepsy, but not for tics. We have to be cautious as we proceed in this field, as the evidence is still emerging. And I would recommend a collaborative relationship between clinicians and patients around this. At this point, the use is mainly in adults. I would be very careful. I'm not going to say I don't have adolescent patients. I do have a small handful of adolescent patients on this, but it's an absolute last resort with them. Okay. And now I think we can do some Q&A. This is the event that Paolo Rita mentioned that for next week. I'll leave it up there for now, just in case people need to get the details.
Okay. Yes. We don't have a lot of questions, but okay, I see now one question there, but I also have a few questions in my mind, and others, you're welcome to post your questions also. So, I'm under the impression that people with ADD or ADHD are more likely to practice self-medication. Is that the factor taken into these studies, that the ADHD is more of the beneficial diagnosis than the Tourette syndrome? That's
So if I understand the question correctly, you're thinking that if they have ADHD, they're more likely to benefit from cannabis rather than the tics themselves. So if I understand, if I have the question right, I will answer it as is. But if I'm getting it wrong, please correct me. But basically, Okay, thank you. Confirmed. No, actually, I would say the effect is very specific to the tics. So I'll start off with that. So we have patients with tics and no ADHD, and it's really what you see is decrease in the tics. Now, often patients will report, patients who do have ADHD and OCD and anxiety and other challenges will often report an improvement in the other challenges as well. Okay, but those are not being targeted. What we're doing is we're targeting the tics, and it happens that on the whole, these other symptoms improve as well, which is interesting. But that's different than studying it directly to target these other symptoms. And I think it's worthwhile to study the impact of these other symptoms, but I don't think we have enough evidence at this point to say that it decreases ADHD or improves other things, other than to say that, whether in our experience in Toronto, but similar to Kirsten Mueller-Wahl and others' experiences, that often comorbid symptoms improve. Is it because comorbid symptoms improve because in the context of Tourette syndrome, meaning that if you take cannabis in Tourette syndrome, ADHD could improve, but not necessarily ADHD outside of Tourette syndrome. We don't know. Uh, or is it when the tics are very significant and they impact the other things as well, including your ability to focus? And as the tics improve, you're better able to focus. These are all things to discover.
Okay, I have a similar kind of question continuing this topic. I was wondering that is it clear that this THC is affecting directly for the tics, or is it affecting for the anxiety? And while the anxiety levels lows, then the tics reduces, or is it clear that its focuses directly to the ticking?
So I can't say it's fully clear, but I do think it's a direct tic effect. And I'll tell you why, Paulo Rita, for a couple of reasons. One is the tics decrease, and we're talking many patients who don't have difficulties with anxiety. Okay. So a lot of patients have significant tics, but anxiety is not something they struggle with. And the tics go down in these patients. So that's one. The other thing is the role of THC with anxiety is complicated. It's not that we don't have the evidence of THC helping anxiety is not so clear cut. I would say that's still being studied. Um, and in fact, there's often patients will experience, not all, I would say a minority, but a significant minority will experience increased anxiety with THC. So I do think it's a specific tic effect, but this is me concluding this kind of from the overall evidence as opposed to it having been studied very directly.
Thank you. Okay, there's a new question. In your experience, are there clear inclusion criteria for cannabis treatment, age, or tic type, etc.?
Thank you. I would say I wouldn't call it clear inclusion criteria, but it's something we need to think about. So, um, first of all, age is an easy one. I would say absolutely adults. Okay, meaning that with kids, it is not something I think about unless I'm desperate. Okay, and so when I'm desperate, so I do have a small handful of adolescents who have had severe tics and not responded to our main treatments, so behavioral therapy and multiple medication trials, etc. And then I've proceeded to the cannabis in their case. But well, I would say it's been pharmaceutical cannabinoids, so I haven't gone to cannabis with them. But basically, absolute last resort. But with the adults, I'm less concerned that way. But even then, I prefer that it's not the very young adults. So generally, I prefer if it's over age 25. But in truth, I've had older teens for various reasons, or who are using it already and it's working for them, and but basically the preference is adults. So that's in terms of age. Tick type, no, we don't know anything about tick type. I think it's an interesting question, not just for cannabis, for any intervention, really, almost any intervention. For the most part, we don't know what types of ticks are more likely to respond to one medication versus another. Again, with a couple of small exceptions, such as, anyhow, I won't get into them now, but happy to. And then the last thing I want to say is, I'm still not at the point, like if I see an adult, let's say a 35-year-old who comes in for the first time with significant tics and they want treatment for their tics. So the first line treatment is going to be behavioral therapy. I think that's not controversial at all. But let's say that didn't work out and we want a pharmaceutical product, a chemical product, then would I talk about cannabis early on without even having tried the other stuff? No, I'm not at this point, and I don't think the evidence would justify us to go at this point. So if they need a chemical, then I will talk about alpha-2 agonists and antipsychotics. But we're not at a point where we can so early on talk about cannabis. But I do, if they're not doing well with the agents for which we have substantial evidence, then I will talk about cannabis for sure.
Yeah. There was a second question. Is it continued to the past question? I don't really understand. Relative to duration or cycles continues. Did you catch that?
I think I understand the question. I think like do you use it ongoing basis, or do you use it for certain periods of time? That's a good question. I would say with any treatment, you should check if it's still needed, because tics might be improved for various reasons. For some treatments, it's easier to stop and restart. For others, it takes a long time. Like the alpha-2 agonist, you have to go up quite slowly. You have to come down quite slowly. Uh, But with cannabis, I think yes, you can. I would say you should always again check if it's still needed, and then I think you can. If a person has been on a high dose for a long time, stop suddenly, I think you will have withdrawal like from anything you take regularly, whether it's something prescribed or coffee or anything. So I would recommend going down gradually, still there, but generally, it's taken for an ongoing time for I'm not going to put a number, but for a period of time. But you always want to check if it's still needed. Okay.
Okay. Can I have my own question in this?
Yeah.
What were the cannabis that was used in these RCT studies? Was it the medical cannabis or like a real cannabis?
So in the RCTs, so in the two Australian RCTs were oil, a cannabis oil, and it was a combination of THC and CBD in both cases. In the RCT by Kirsten Muller-Wahl, so I'm talking about the four most recent RCTs that I covered in detail, and the one by Kirsten Muller-Wahl was the spray, the nabiximol spray, and that was a negative RCT. And which is also a combination of THC and CBD. And then our single dose RCT that was inhaled, where we compared THC, CBD combo and placebo. And what is clear is the anti-tic effect is coming from THC, and there's nothing from CBD. Okay.
Yeah.
People still use CBD in combination with THC, thinking that it can decrease the harms of THC. I think that's questionable, and I'd rather decrease the dose of THC rather than add CBD to the THC. But that's to be evaluated more. We don't know enough about whether THC will decrease harms of THC. Whether CBD decreases the harms of THC without so it decreases the negative effect of THC without affecting the positive effects. I think that's a bit of a stretch. It needs to be studied properly.
Yeah, because I've heard some discussion about the medical cannabis that some people are worried because they just separated some really specific like a substance compared to using the real cannabis. There are a lot of other things that might also have an effect. So
I mean, I have to say, in our experience, there's not been a proper randomized design study comparing, let's say, cannabis, actual cannabis to a pharmaceutical. But definitely in our experience and the experience of Kirsten Muller-Wahl and others, it looks like the cannabis with everything that's in it works better than the purified pharmaceutical grade products.
Okay, we're about to run out of time, but do you think we have still time
Sure,
for the last question posted on the chat?
Yeah.
So considering the current evidence, what are your consideration risks, benefits for children and adolescents regarding cannabinoids treatment for tics and Tourette?
Well, this one, I think we have to be very, very careful because, first of all, children are susceptible to any adverse effects more than adults. But there's one in particular, which is that of psychosis and chronic psychosis, meaning that if you're taking the product regularly and you get psychotic and stopping it, and the psychosis remains even after stopping the product. So that risk is age related, meaning for younger children, for adolescents, even generally people say below the age of 16, but I would say any youth, we should be very careful because that risk is very much age related. Okay, so that is my main concern there. And so when we're prescribing cannabis, it's not a one-off. This is something they're taking every day. And so this is the main risk when it comes to children, adolescents. So, and in general, this is something that's still being studied, still not fully studied. So we need to be very careful. I'm not saying never, but we need to be very careful in how we proceed to study. We need to study it well and how we use it clinically.
Okay, thank you. I have still a lot of questions on my mind, but we're about to run out of time. And luckily, we have the next event coming, so maybe I'll save my questions there.
All right. That's great.
So,
Thank you, Paulo Rita. And yeah, hopefully there'll be much more discussion there. And people have different perspectives. Today was me giving the intro, but there's going to be other experts, including someone with who has very personal experience with using cannabis for tics. And so you'll hear from the multiple perspectives.
yeah. Thank you for this really, really interesting presentation. And it was my first time hearing this topic discussed this way. And I'm super happy to be here today. And thank you. And I'm excited waiting for the next event.
It's my pleasure, Paulo Rita, and thank you and the other organizers, and thank you everyone for attending.
Thank you. Okay, so hopefully we see you all in a couple of weeks. And in the meantime, do follow our social media account, TTAC, and our website. I posted there the link, ticsandtourette.org. There's more information about the upcoming events. So have a nice evening or morning, everyone, and see you next time. Bye.
Bye-bye, everyone.